5. This morning we are greatly honored to have a visiting speaker all the way from Florence, Italy. Dr. Iacopo Olivotto is the head of cardiology at the Mayo Children's Hospital and head of cardiomyopathy service at the Calgary University Hospital and Professor of Cardiovascular Medicine at the University of Florence. Over the last 2 decades, his main clinical and research interests have included various aspects of cardiomyopathies with a special focus on translational investigation of hypertrophic cardiomyopathy. Professor Olivotto has participated in the design and execution of randomized clinical trials in genetic cardiomyopathy, including the seminal Explorer HCM trial, of which he's a lead author, and the Sequoia HCM trial, which involves cardiac myosin inhibitors, which we all know have really revolutionized the care of hypertrophic cardiomyopathy. Professor Olivotto is the co-founder of the Sarcomeric Human Cardiomyopathy Registry, also known as SHARE, and ICON, and is a member of the Hypertrophic Cardiomyopathy Medical Association. So welcome, Dr. Iacopo. We really look forward to your talk.
Thank you so much. I'm really deeply honored to be here. And I'm usually known in my department for being the only one without a tie at meetings, and I'm the only one with a tie today. So I'm on the other side of the world. So see if I can scroll this. So these are my disclosures. And of course, as you know, everybody who's in cardiomyopathies would have an empty slide for many, many years until very recently. So it's good to actually have something on the slide because that means that the field is moving forward. First of all, I had a depth with Canadian cardiology. I was in some way a mentee of Dr. Weigel, who I met personally. He was at my house for a dinner based on pasta, of course, and he was the ultimate gentleman. He taught me a lot by his papers, but also in person. We had a fantastic trip to China together to a meeting. He's really an unforgettable figure. So I've often come across the incredible quality of Canadian cardiology. So let's go right into the topic of my talk today, which is really assessing the progress and sort of novelties, but also the history of pharmacological treatment of hypertrophic cardiomyopathy. And we do talk about history because we have stuff that has been there for 50 years, virtually unchanged, and used largely in the absence of solid data just because it works or we think it works. So in patients with hypertrophic cardiomyopathy, there are a good number of reasons why we want to give drugs, and it's mostly because these patients are symptomatic. They have obstruction, they have arrhythmias of all kind, and of course they may progress to heart failure. Of course, you can see from these indications that none of this addresses the etiology of the disease or the core pathophysiology. We're just scratching the surface of what's happening in these hearts and trying to mitigate the complications. So we haven't been very ambitious and unavoidably so far, just because we didn't have much to go by. And obstruction has always been the most sort of obvious objective for treatment, simply because it's not unique to HCM, but it's pretty sort of a sort of hallmark of the disease, because it's so common in this disease. And why is it so common in HCM? Because it's like really a conspiracy, a natural conspiracy. You have long valves sitting in a small ventricle, hypercontractile, with the outflow flow that's outward flow that's severely misdirected posteriorly by the hypertrophy, and that creates systolic anterior motion. And we know that surgery is the gold standard for this. And of course, in Canada, US, you have incredible surgical centers that can do incredible myectomies. This is a young patient with troponin T disease, which we operated in Florence. And Professor Iacopo himself started our program in Florence, so he did this myectomy. You can see how beautiful the myectomy is. Despite the myectomy, after 12 years, the disease progressed, and you can see that the girl is now in end stage, and we are considering heart transplantation in this unfortunate patient, despite a fantastic result of surgery. And this is data we recently published in Circulation, looking at the very long outcome of our patients with obstruction in SHARE, which is a large international consortium with over 10,000 patients now. And following what is the natural course of the cardiomyopathy following successful septal reduction therapy, so myectomy and alcohol ablation. And you can see that if you wait long enough, patients, of course, have a huge advantage from surgery. And even in centers that don't have a huge flow, I mean, all SHARE centers are not the Mayo Clinic, not Cleveland, not Toronto. They are sort of centers that have medium flow of surgery, but they have a huge clinical experience. And their results are really good in terms of mortality and gradient reduction and symptom reduction. But what obviously happens is that even though the gradient doesn't recur, the disease progresses. This is unavoidable. This is a cardiomyopathic process, and we'll talk about this in a minute. And if the longer you wait, the more you will see patients that progress into the other kind of heart failure that you have, which is not related to obstruction, but it's related to the myopathic process, so progressive dysfunction. So going back to treatments, to drugs, of course, we are using beta blockers a lot. We use beta blockers a lot because they have been shown to work by World and others. They sort of may be useful in reducing the gradients, improving our filling time just by reducing the heart rate. But at the same time, we know that we impair patients' exercise tolerance, for example, and the Explorer trials has shown this very well. Patients who were on beta blockers, and they were the majority, did not increase their peak VO2, which is understandable because peak VO2 is heart rate dependent, compared to patients who were not on beta blockers. We know that we often induce chronotropic incompetence in our patients, so much so that in Medscape, this is recent, as you see, June 2026, somebody spoke about the tyranny of beta blockers. So we impose on our patients these sort of time-honored treatments, whether it's HFpEF, whether it's regular systolic heart failure, or whether it's HCM. And in fact, we are often giving them side effects which we are not even fully aware of. And there are trials now in HFpEF showing that if you reduce or withdraw beta blockers, some of the patients are actually doing a lot better, particularly those that have documented chronotropic incompetence. So definitely we are in a stage now, and brief touch upon this later, where with myosin inhibitors, we are beginning to understand that background therapy we're giving to these patients with HCM is probably not the best thing we can do for them, even though some patients may benefit from beta blockers. And if you use beta blockers judiciously, some of the patients will have sometimes important benefits. So not discarding the whole concept, just making sure we don't make it the standard in the absence of strong data. What about disopyramide? As you know, disopyramide is a class 1 antiarrhythmic agent that is used in HCM, in obstructive HCM, because of its negative inotropic action. It has anticholinergic side effects, and it tends to have tachyphylaxis. So it rarely does a job for good, but it can be extremely effective in the short term or in the midterm, even in best hands. So Mark Sherritt's center in New York, we know that less than half of the patients remain on disopyramide for long term, and the others have to go to septal reduction therapy. And he's really going a long way in order to keep the patients on, including giving them a period of stigmine to mitigate side effects. This is actually a very interesting drug. So we found recently out that there was really nothing to characterize the effects of disopyramide in human myocardium with HCM. So we have a pharmacological lab in Florence that does a lot of these studies, and we provide a lot of myectomy samples. In this study, we actually characterize the effects. And it's interesting because disopyramide is a very dirty drug. So it blocks the peak sodium current, the late sodium current, the L-type calcium channels, HERG, which is a erythropoietin current, which is the reason why you have QT prolongation, because of HERG block. At the same time, you block the ryanodine receptor. So, and we like dirty drugs. The dirtier antiarrhythmic drugs are, the safer they are usually, and the more effective they are. Think about amiodarone. Of course, amiodarone is a terrible drug, but it's safe and it's very powerful. Why? Because it blocks everything. So in this case, you have a drug that's a little bit like verapamil, a little bit like ranolazine, a little bit like flecainide, and what it does in vitro is it sort of shortens your action potential. This is human HCM myocardium. We know the action potential to be grossly prolonged in this disease because of overactivation of the late sodium current. So you can see that in vitro, you can see that the reduction in action potential, reduction in tension. This is the negative inotropic action, which you're looking for, and it's due to the block of the peak sodium current. And look at this, the suppression of the early and late after depolarizations. These are important in vitro markers of arrhythmogenicity. In an era of MRI, everybody's obsessed about the scar, delayed enhancement, and we say the more enhancement, the more scar, the more arrhythmias. But this is, in fact, what creates the arrhythmias. It's the presence of these cellular triggers that actually start the whole process. The re-entry process is part of this, but we have some preliminary data showing that if you have a scar and you don't have post-potentials, we have followed about 100 patients in whom we had myectomy samples, and we looked at this. We have the scar, and we have late potentials, and sustained VT. Scar you don't have in vitro, don't have post-potential in vitro, nothing happens. Scar is neutral. This also explains why we don't send these patients for ablation very often. You don't have sort of standardized stereotype reentries. It's a diffuse mechanism related to cellular triggers of arrhythmia. It also explains why disopyramide is actually a very safe drug, despite the concerns for QT prolongation. All the studies have shown, if anything, a signal towards increased safety, not increased hazard. And this is why I also use it a lot for topics and non-sustained VT. It works very nicely. So it's a nice drug to consider, even when you're not so effective on particular arrhythmias, and patients feel better, palpitations go away. So, provided your QTC is under control, so meaning below 500 milliseconds, it's a drug I often use for this disease. Okay, but again, what about something better, more novel? And of course, we are now moving to talk about the myosin inhibitors. And this is quite interesting, because I've been involved in hypertrophic cardiomyopathy for almost 30 years now. And we've been fixated on the hypertrophy. So I can recall endless debates, endless meetings, AHA, ACC, ESC, 25 millimeters, 30 millimeters, 29 millimeters, apical, anterolateral, lateral, symmetrical, asymmetric. So everything about the essence and importance of hypertrophy. And we sort of seem to have forgotten that we scotomize the fact that these are hypercontractile hearts. These hearts contract like crazy. And nobody ever paid attention. I didn't. Look at the image here on the right. And of course, you're forgetting about hypertrophy for a minute and just looking at what happens in the cavity. This is a midventricular obstruction patient with apical aneurysm, and it's clear that some sort of this degree of contraction at rest is not physiological. And you only realize this once you've seen it, you cannot unsee it. But it's hard for us to see it. Why? Because cardiologists are trained to perceive drops in ejection fraction. So if you have somebody with 45 ejection fraction, you get nervous. If you have somebody with 30% ejection fraction, you get extremely nervous. There's a real reason for it. But if you have somebody with 80% ejection fraction, you don't care. You don't notice it. And we don't even report it in echoes. We just write 65, that's it. It's only when CMR came about and quantifying exactly the ejection fraction that we started to find out patients with 80% ejection fraction, 75% ejection fraction, which is actually what these patients have. On average, HCM patients have 72, 75 ejection fraction, percent ejection fraction. So that's really high. Why? They are doped hearts. These are genetically doped hearts. myosin in the evolution, because some of the changes in myosin may be quite advantageous. And I would put it to you that Usain Bolt's myosin is much better than mine. And there probably is a reason. And so there's continuous occurrence of mutations and of course, these are quite compatible with life, even when they create disease, so that they are quite widespread in the population. We're talking about 1 in 200 individuals have variants, not saying have the disease, but have variants in the myosin or other sarcomeric proteins. The way myosin works is in dimers, and so there are 3 states of the molecule, and this is the cardiac myosin, which is a lot different from skeletal muscle. So the vast majority of these molecules are either in the super relaxed state, which is this one, which is virtually 0. It's prevalent in hibernating animals and in government employees. I'm a government employee, so I can say that. But then you have a disordered relaxed state, which is an intermediate state here. So it's there, ready to jump in, but not active. And then you have the active state, which is only about 10% in nature. Why? Because this has to be sustainable. Your heart has to keep you alive for 90 years and has to repair itself while working, has to work constantly. So it's obvious that you need to have a huge sort of backup system, and only a fraction of these molecules are active. And all the ACM-associated variants that we know, as you know, a lot of patients are gene elusive. But in the gene-positive patients, whether they have beta-myosin mutations, whether they have mutations in the surrounding genes, the net result will be myosin activation. If you have a myosin mutation, it's again. If you have beta-myosin disease, as you know, that's mostly hypertrophic insufficiency. So you have low levels of the protein, but beta-myosin, the protein C protein is actually a handbrake on the myosin. So you remove the handbrake, and the result is the same, hyperactivation of the myosin. Same for troponin disease. So the net results of all these sort of natural dopings is that you have increased calcium sensitivity and increased tension cost, increased contractility, and of course, as always the case in nature, reduced relaxation. Whenever you increase contractility, you reduce relaxation. That's the law of nature. And this is irrespective of the genotype. This is also results from our lab in Florence. But of course, other labs have come to similar results. And of course, in the long term, this can actually be not too bad at the beginning of disease, particularly in milder phenotypes. So some of our patients will tell you that when they're young, they never get tired. They have incredible exercise performance. We've had Olympic champions. We've had people who've had incredible athletic careers, and then start sort of building up symptoms and dysfunction and scar because the system becomes non-sustainable in the long term. Sometimes this happens very, very quickly, even in children, and you need transplantation. Sometimes you live up to 90 and nothing really much happens just because the system has found a balance. So you have all the intermediate. So the idea was around for a while, can we interfere with these molecules so that we can find drugs that are effective in reducing the consequences of these mutations just by modulation. Don't forget that beta-myosin, like it or not, is an enzyme. So it's a contractile protein, but it's in a TPase. So like any enzyme, you can change its kinetics if you have an allosteric modulator that binds to it. And of course, the idea, again, didn't come to treat hypercontractility, but came because we were so concerned about systolic dysfunction. The first drug to be developed in this field was, the first myosin modulator was omecamtiv mecarbil, which was developed for dilated cardiomyopathy. And this is actually a very interesting drug. It's an unlucky drug because what it does is it improves, it activates myosin molecules so that the number of hands on the rope increase. And interestingly, this is, to my knowledge, the only inotropic positive agent that doesn't increase your calcium transient, doesn't increase your energy consumption, and this is why it doesn't increase mortality in the long term, as opposed to all the other sort of positive analogs that have been tested in chronic heart failure. The trial, that Galactic trial that sort of showed its efficacy in clinical practice, showed only modest advantage in a combined endpoint, which was largely due to reduction in hospitalization. For this reason, FDA has asked for further data before allowing its sort of approval, and so it's not clear what's going to happen. Hopefully, the drug will be revived because at present it's not available. And I think it's a very interesting drug, particularly for cardiomyopathies that have sometimes very low blood pressure, don't tolerate other other medications, particularly because this drug has proven to be super effective in the patients with the lowest levels of ejection fraction. So the most fragile patients, as you can see here, are the ones where the treatment effect was greater. So I still think it's a great drug, and hopefully, I was not part of any of that development, so I have no conflicts here. I do hope it's going to be available. But in the case of HCM, we wanted just the opposite. So mavacamten and then aficamten were identified by screening a large number of molecules that did exactly this. As you can see here, you have silicon plates with myosin heads and actin floating freely on it, and they just automatically contract so that you can actually see this happening. And if you add an allosteric modulator, this is what happens. So it's scary, if you like, to think that we would ever develop intentionally some drug that would decrease your contractility. Again, this is taboo for us, but this is exactly what happened. And this is one of the very few cases where Murphy's law didn't apply. So there was like a nice pipeline going from knowledge of pathophysiology, identifying a target, development of a drug that proved to be safe and effective in vitro, in the animal. In the animal, there was actually incredible data showing disease modification, suppression of profibrotic genes, and regression of the early phenotypes. And of course, moving on to the clinic. This is where big questions came up, because this was a drug developed to counter HCM, not a drug developed to counter obstruction. But when it came to going to clinical trial, the question is, should we go with an all-in sort of symptomatic patient with HCM, full stop? And we quickly realized, first of all, that we needed an endpoint, because you can't do mortality studies in HCM because event rates are low, fortunately low, and it's very unpredictable. Sometimes you need decades to see something happening. And on the other hand, that probably focusing on obstruction would be the ideal because gradient is measurable, gradient creates symptoms, gradient associated with outcome. We have data from myectomy spanning 50 years that show what a benefit you can get from reducing the gradient. So let's go for it. And so the trials, as you have seen, the phase 3 trials in mavacamten, Explorer and Valor, and in aficamten, Sequoia, have been designed for symptomatic obstructive HCM with the endpoint of functional capacity, peak VO2. In Explorer, there was a mix of peak VO2 and YHA class improvement. The studies in non-obstructive HCM are Odyssey, which is a large multi-center study in non-obstructive symptomatic HCM, will be available in terms of top-line results probably in April and be presented at the ESC. So FDA approval, ESC approval, approved in Canada, approved in many other countries in the world. And again, the two seminal trials here, the two phase 3 trials, are actually very similar. Very small compared to heart failure trials. The endpoint is very soft. This is why the negotiation with FDA has been quite delicate and important. This is also why Explorer was not accepted in the New England Journal of Medicine and was directed, and that's a phone call I received literally 15 days before presenting at ESC in 2020. I got this email where the paper, after sort of having agreed to do a contemporary publication, simultaneous publication, just rejected the paper because of many other studies competing. And we had to send it to the Lancet, and we received 10 pages of comments from the reviewers and had 48 hours to respond. So that was not a good time. I was actually on vacation. It was July. But anyway, so aficamten had an easier life. The two trials are similar. The size of the sample will in the range of 200 to 180. Similar enrollment criteria, so symptomatic patients with obstruction at least 50 meters of mercury on provocation. You can see that the main difference between the two drugs is aficamten has a half-life, mavacamten has long half-life. Mavacamten has a hepatic metabolism strongly dependent on CYP2, C19, cytochrome that metabolizes clopidogrel, for example. And therefore, if you have full metabolizers, which are more abundant in the Asian population, this may prolong very much. You may have a super responder, although this has not been really proven. Longer half-lives of the drug. Otherwise, the action is similar. In molecular terms, it's probably not the same because these drugs stabilize myosin in different resting states, but the concept is similar. So they bind to myosin and sort of favor the stabilization in the resting state as opposed to the active state. Duration of the trials is similar, 30 weeks versus 24 weeks, randomized 1-to-1, placebo versus the active drug. Background therapy, similar. In Explorer, disopyramide was not allowed, but in Valor it was allowed. In Sequoia, disopyramide was allowed from day one. There's a lot of obese people enrolled in the US, but otherwise, as you can see here, it's pretty much similar. So class 2, 3, and with maximal exercise and some exercise limitation. So the results here in terms of the endpoints. The primary endpoint in Explorer was a mix of NYHA response and peak VO2, but here for the sake of clarity, just the results are shown. There is a significant improvement, although it's not massive. You would expect a lot more if you compare with myectomy, for example. You would expect a 3 mil in peak VO2, and it's only like 1.5, 1.7. But heart failure specialists tell me this is not trivial. It's quite important, particularly because, again, most of these patients were on beta blockers, were heavily beta blockers. So if you look at non-heart rate dependent variables, the effect is actually larger. But of course, what we are all looking at always when we think about septal reduction therapy is what happens to the gradient. And the gradient falls, as you can see here, by about 50 millimeters of mercury. I'm sorry, I don't think you can see the pointer, but it's the second line. The gradients go down by about 50 millimeters of mercury. This is provocable gradients in both cases. And the number of patients who improve at least one NYHA class is approximately 60 to 65% in both studies. So what these drugs do is they basically turn your expensive but unaffordable Lamborghini to a diesel truck, and which is really what the heart should be. Your skeletal muscles should be Lamborghinis, but your heart should be diesel trucks. And we have a number of consistent, very solid evidence, which is actually spanning now almost 3 years for mavacamten and a little less for aficamten, that shows that these treatments are effective in reducing gradients, symptoms, biomarkers, quality of life, and promoting some remodeling of the hearts, which is, I know you already have seen already by MRI here and here. We still don't have very solid evidence that it's disease modifying or that it changes outcome, because these data will probably only come from real world registries and thousands of patients just to have the power to see any effect on outcome. So this is the top line result from Explorer. You can see here provocable gradients. Placebo is relatively stable. In blue, it's the treatment arm that shows very nice consistent reduction in gradient. The safety side of things is really, again, this is a negative inotrope, has no ceiling effect, has the potential to take your systolic function to 0. But in the doses used in the trials, and we now have very nice data I'll show you in a minute from real world, the drop in ejection fraction is actually quite small, only 4% on average, and similar in Sequoia, in aficamten. So the drug, I remember, has mavacamten in particular, acts slowly. takes about a month to see the results, 2 weeks with aficamten. So it starts by reducing your Valsalva gradient. And this is data from Pioneer from the phase 2 study. And I'm sorry, I'm not sure everything is running here, but it takes a while. First, the Valsalva gradient goes away first, and then if you wait long enough, about a month, and then you can titrate, but sometimes 5 milligrams is sufficient, which is the starting dose. You can see the gradient go away, and you can see systolic function is not depressed. I mean, it's still very much in the normal range. And this is also data that Steve Heitner provided to me from Pioneer. It was like, out of his, was completely amazed, as the others that were part of that study, looking at how well the patients were doing and how dramatically BNP went down as well. And of course, we were able to replicate. This is a Florence patient from Explorer. You can see that in best case scenario, it's not always like that, but in best case scenario, you do have surgical results. It's a chemical myectomy, if you like. It can be so dramatic. And we have now cases coming in from many other centers in Italy. Colleagues send me all the little nice cases. And so some of these are just regular obstructions that some of them have combined subaortic and midventricular obstruction. They seem to respond as well. Isolated midventricular are not part of these trials. They are part of Odyssey and Acacia, so they will be part of the non-obstructive trial in particular. But if you have combined obstruction, LVOT and midventricular, you can use the drug and it works quite nicely. This is another responder. This is in aficamten. I'm sorry, the moves are all going. So this is to show that even in older patients with sigmoid septum, where you would think, hey, this is not going to work. This is geometrical. This is a geometrical abnormalities. In fact, you can have some dramatic responses as well, and you can see that systolic function can be preserved. It's not 100%. You may have some failures, but it tends to be quite effective, quite consistently. The improvement in diastolic parameters is quite striking, and that's largely due to the reduction of the gradient. In non-obstructive patients, it's actually harder to see this kind of results. It's harder to see a big change in the pattern of diastolic function because it's just so hard for any drug to do this. But in obstructive patients, you do see it. And of course, very consistently, reduction in biomarkers, proBNP, troponin. That's the same for MAVA, the same for aficamten. And also, it's a very sustained long-term effect. If you look at a larger number of biomarkers, which is a panel that was done here with mavacamten, it's actually quite complex, but all these changes here are beneficial. So whether they go down, whether it's down-regulated or up-regulated, these are all sort of potentially beneficial effects. So we are changing something very deep inside. But of course, what patients want is quality of life. And this is important because they don't care about gradients. They want to feel better. It's quite amazing the placebo effect that these patients have. We know this from the very old pacemaker randomized trials in the 90s, that patients felt better with a pacemaker on, even if it was not one active, and they had the gradient that was unchanged. But of course, even though the placebo effect is huge, and of course these are dynamic gradients, symptoms are erratic, so it's quite easy to convince yourself that you're better. But at the same time, 70% of patients here in Explorer had improvement in quality of life, including, as you see here, about a third that had very, very consistent and very, very large improvement in quality of life, which means this. It means patients resuming their activities that they had lost, long forgotten, or sort of resolving some of the symptoms they never knew they even had. And the effect is very sustained. So if you at any time interrupt the drugs, for what we know, everything goes back to baseline. So it's not a permanent effect, but it is sustained as long as you are on the drug. And as you can see here, for example, on the gradient, it becomes more and more consistent. The confidence intervals become smaller, probably because of the remodeling. And if you look at the real-world data, it's actually quite comforting to see that, again, here, about 90% of patients have improvements in symptoms. So the vast majority, about 9 out of 10, which is really what the VALOR trial has told us. And in terms of safety, we know that about 7% of our patients on mavacamten will develop at some stage, a transient drop in ejection fraction below 50%. That's something that worries, but in fact, it very, very rarely goes below 40%. That's almost never seen. And even if it does, it very seldom leads to heart failure events or hospitalization. It's usually the patient's coming back saying, I'm a little fatigued, something has changed, I'm not as good as I used to be just a few days ago. And you check and the function, you see the function has reduced, sometimes in the context of paroxysmal AFib, for example. And at that point, if it's mavacamten, you have to wash out for a month and reduce the dose, unless the reduction is really severe, or unless you have had drops on the lowest dose. But it usually is not the case. Most of these patients, the vast majority of these patients are able to resume at a lower dose. With aficamten, you don't even need to withdraw the drug because in the trials performed so far, the protocol did not entail a withdrawal, just a reduction of dose as you go, because the half-life is shorter. So they're actually drugs that are easier to handle than we thought. And the data from real world, as if you can see here in the, here at the bottom right, only less than 3% of patients had systolic flexion in this sort of almost 2,000 patients from real world in the US. This is probably because clinicians in real world are not pushing the dose as much as we have done in trials, which is, I think, reasonable. There's no rush. In terms of remodeling, this is very limited data from Explorer, but it's the best we have as yet. Although many other data will follow, many studies will follow, I'm sure, from many centers, including here, I guess. You can see that there is definitely some thinning of the septum, some reduction of the LV mass. It's small but significant. The atrium reduces as would be expected, and the ejection fraction only reduces is only mildly reduced. What is really striking is really the geometry. This is not something it's easy to quantify, but this is the same heart at the beginning of Explorer and after only 30 weeks. Sorry, this is after 3 years. Sorry about that. This is the long-term follow-up. So you actually need at least 2 years to see this kind of change in the heart. But what happens is that you realize that the heart at baseline was never end-diastolic in its life. These hearts have never been end-diastolic, never. So one of the reasons they look so thick and they look small is because, in fact, they were never able to relax fully. It's like a flower that never sort of opens up completely. And mavacamten and aficamten does that. They actually allow these hearts to open up. So they just by doing that, these hearts look thinner, they look more normal, they contract more normally. If you look at the apex, and sorry if I can go back one. It's quite amazing how anyway, the way the geometry has changed. If you look at brain, despite this being a negative anotrope, or maybe because of that, and you have better relaxation, you can see that the heart deforms better, and also that the mechanical dispersion is a lot better. We know obstructive hearts to be very asynchronous. Whereas here, this is only a small cohort from the Florence Explorer cohort, but quite consistently, except for one non-responder who went into AFib, but the others have this improvement in electromechanical dispersion. So not only the peak systolic dispersion, but also if you look at the panels on the right, QT dispersion. QT dispersion improves very dramatically, which is really quite important because these are all predictors of arrhythmias as well as performance of the heart. So these hearts improve their performance because not only the heart relaxes better, but it contracts in a much more homogeneous and synchronous way, which is not something you would not see with surgery because of the left or alcohol relation. So it's a bonus that you have. If you look at the morphology of the ECGs below, these are 6 individual patients, you have this consistent improvement in repolarization, which is striking and not expected. You don't see this with disopyramide with any other drug, even when the gradient goes down. It can be as dramatic as this. And this is also reversible. You take the drug away and the ECG goes back to baseline. And this is probably electrophysiological. Remember what I told you about late sodium current, the Herc current, all the sort of abnormalities of the currents occurring because of these calcium overload, of these disarrangements in the cell. So I think the ECG changes reflect this, a normalization of the currents and the calcium overload. If this is the case, we can then very much hope that there will be a reduction in those post-polarization, post-potential. Don't have any data to prove that, but it's wishing well for our patients in terms of arrhythmia risk as well. So rapidly moving across guidelines, as you know, in August 23, we presented the European guidelines, and mavacamten was now the only drug, and still the only drug approved in the world, was included as a Class 2A indication. Class 2A, because it was such a young drug with limited safety data. We now have a lot more data. And it was on par with disopyramide, which is a little odd, but that's probably at that time was a little too young. The American guidelines, only 6 months ago, changed to myosin inhibitors as a class and indication to class 1 because Sequoia had come out in the meantime. And as you can see here, these drugs now are on par with disopyramide, which is probably going to be like second sort of position, and on par with surgery. So it's interesting. Now, instead of going through all your medical options before going to surgery, you have to discuss with the patient saying, look, beta blockers are good, but didn't work. Calcium antagonists didn't work. Now, what do you want to do? Because now we have an option where you can decide whether you can go for a surgery straight away or try a drug that may postpone or avoid surgery for you right from the start. And I actually enjoyed reading the Canadian guidelines because, again, I see that this is the same approach. And I think it's really the right approach here is to discuss right from the start the different options, because if you go for cardiac myosin inhibitors, it's actually a parallel pathway to surgery at this point. It's not something that will kill surgery. Surgery will remain and is important because we have patients with organic sort of structural mitral problems, endocarditis, ruptures, or who fail to respond to the drugs. And so we need to keep that skill abundant. But of course, alcohol ablation, I think, is going to suffer a lot. It's going to probably taper out because the results are not as good as surgery and not as good as myosin inhibitors. And operative risk is still not small. But at the same time, we're reminded of this gentleman. This gentleman is Dr. Billroth, who's a German surgeon, and he invented the Billroth 1 and 2 operation, which I'm old enough that when I was at university, I used to study the Billroth 2 operation, which was a gastrectomy that was used for cancer, but also very, very actively for gastric ulcer in young patients. And it was cool, it was very effective, and you performed this operation on young patients for a benign sort of problem, which at the time led to bleeding. And of course, in 1982, I'm not that old, I mean, I was after that, but anyway, in 1982, in 1981, ranitidine came about, and nobody now would think about operating somebody with a gastric ulcer. So in some extent, it's our sort of duty to take some work off the surgeon in terms of preventing medically what would otherwise be operated, but that has never left the surgeons without a trade. So I don't think this is really going, and again, this is Explorer. The trial Explorer was aimed specifically at patients with a surgical indication. So it was actually performed at surgical centers in the States, including Cleveland Clinic. So I was surprised because I never thought the trial would happen, especially performed by surgical centers. But the reason for inclusion was patients who had a clear guideline indication for surgery or were actually listed for surgery. And of course, 100% were listed at the beginning of the study. And as you can see here, after only 16 weeks, only about 80% of patients had dropped out of the list because their gradients had improved so much and the symptoms. In the placebo arm, you had a natural drop of 23% for reasons that are related to the variability of disease. But then they also switched to mavacamten, as you can see here, the dramatic drop again. So about 8 to 9 patients out of 10 will drop out of a surgical list. And data with aficamten are absolutely comparable in Sequoia. There's discussions about the costs. So are these drugs affordable? They're expensive. They are environments. Although in Europe, for example, they cost a lot less than the US. But of course, they are very expensive if you compare those with a one-shot myectomy procedure. What about if the drug is a disease-modifying drug that actually sort of prolongs the life of the patients, avoids the late complications, the refractory heart failure, the fibrosis, which is exactly what it does in the animal model with the transgenic sort of hypertrophic cardiomyopathy I mentioned before. So I think myosin modulation is really a strategy that's here to stay. We still have to learn a lot of things about these drugs. We need to learn which are the potential responders and non-responders, which are the patients who may be at risk of developing systolic dysfunction. Where do you start from? This is just my tips, is start with patients that would not be surgical candidates for a number of reasons. Patients that have trouble sort of may go have a block for following surgery, for example, or patients that are, for example, a clearly hypercontractile phenotype. Some of the patients have obstruction, but they're not so hypercontractile. The rejection fraction is in the low 60s, and they tend to respond a little less, in my experience. So what you should not do is treat want to become pregnant, because the drug is mavacamten is teratogenic. We don't know about aficamten, but of course, I don't think it will be allowed in pregnant women. So if you have severely symptomatic young women who are looking to have a family, surgery remains a first-line indication. The patient is not so symptomatic. She may quite well tolerate a pregnancy, even though there is an obstructive physiology, as you know. Also, don't start somebody on these drugs if the patient is not compliant. You don't know whether he or she will come back to the visits, and whether she's not reliable in taking the drugs, or she may take two at the same time and may overdose, or you don't trust the sort of reliability of the patient. So it's important at this stage, when we are sort of experienced with the drug, to give it, but we will be able to interact and are reliable. Again, these are the challenges. The other thing is, the other challenge is, except for the other one, collapse, because I don't know, I know in Canada it's not the case. In Canada, it's left more to the physician's judgment. But in the rest of the world, there's a risk mitigation program that involves doing an echo every month during titration. And mavacamten is easy to titrate because it's usually 5 or 10. Few people need the 15 milligrams. So it's only usually one-step titration in 80% of patients. But it's still, and then you still need an echo every 3 months, although the label has recently been changed to 6. So you will need 2 echoes a year, even for definitely once you've finished the titration. We also have a number of patients, particularly in the kids and children, that have severe obstruction symptoms in the context of vasopathies, or sometimes you have a Fabry patient with obstruction. These are not indications because we don't know about the safety. I know there is at least one patient who had Fabry that was discovered after he was starting on the drug and is doing fine. So he's now doing mavacamten as well as enzyme replacement therapy. But usually you should not start the drug in somebody who doesn't have classic HCM. Whether it's gene positive or gene negative, doesn't matter. We know that just come about halfway. We have a nice drug that's registered. Another one will be registered very soon. The drug is picking up worldwide. There are now many, many thousands of patients that are either on treatment or are starting the treatment. And the feedback I get from the real world is consistently very positive in terms of efficacy and safety. But these are all the other aspects we need to look at in the future. So what about the very long-term safety and use? What about the costs? What about the use? And what about non-obstructive disease, which we'll know about in a few months? What about children? We are now starting 2 trials, smaller, but one with aficamten, one with mavacamten, and they're easier and shorter, but just looking at safety, basically, because in obstructive patients. And then we're moving, this is now adolescents, we're now moving then to children, if that is successful. What about use in HFpEF? We have patients that have hypercontractile phenotypes and small ventricles in the general population. And we know that if you have a hypercontractile phenotype in the general population, that is associated with increased mortality, independent of what's underneath it, whether it's hypertension or whatever. So there's definitely a section of the population that would benefit from myosin modulation, and we still don't know. But there's a very preliminary data from the Embark trial, which was a trial in symptomatic HFpEF performed by Scott Solomon. Still very preliminary data, but encouraging. So I think that it's still a long and winding road, but we've come a long way now. And we've become much more ambitious. Rather than just looking at treating symptoms and treating complications of disease, we are now opening a scenario where we're hoping to actually prevent phenotype development and phenotype progression, and therefore really acting at the core of the matter. So this is really what we are looking to show in the next 5 to 10 years, I hope. Thank you very much for your attention. I look forward to questions.
Thank you so much for that wonderful talk. So we'll open up the room to questions. I'll just turn on the ceiling mics. And I'll also open up the chat for everyone online.
Hi, it's Kristen Lyons. Can you hear me?
Yes, hi, Kristen. Go ahead.
Hi, thank you for that excellent talk. I actually have a very specific question that is about something you spoke about at the end. So I have a patient with Noonan syndrome, which is a rhasopathy, of course, and they are in their 30s, so 20s or 30s. And they very clearly, at least on imaging, have SAM, have obstructive cardiomyopathy, and are symptomatic despite beta blocker therapy. And I guess, do you have any experience in mavacamten in this patient? I've actually referred them to our hypertrophic cardiomyopathy clinic. But, if you have any kind of what you do with those types of patients, as I also have a few with Costello syndrome.
Yes, thank you for the question. It's a very painful topic because I do have kids that are severely symptomatic with Noonan's disease, and as you know, it's really hard to treatment, and surgery is sometimes, if it's in an older patients, it's okay, but in kids, obstruction tends to recur, and it's painful. So my feeling is we should really do a study of mavacamten or aficamten in these patients just to look at safety, because I'm quite confident that it would work. The point is that we don't know, because this is such a different sort of mechanism after all compared to sarcomere disease. How would the sarcomere react to a direct myosin inhibition? Would that be beneficial, or would that precipitate something we don't know? So for the caution is of the essence at this point. So unfortunately, we really have to wait and see whether we can gather information specifically for esophages. Having said that, if you have somebody who is really in sort of in need of a rescue, in kids we use a lot of things off label. I mean, virtually all pharmacological interventions in kids are off label. So I would not exclude the possibility you can apply for a compassionate use, individual use in very specific cases, but it would be off label.
Thank you.
Excellent talk. I really, really enjoyed it. I first just a comment, just to agree with you that I think that a lot of what we're seeing acutely with mavacamten with respect to apparent remodeling, the wall thickness getting apparently quite less prominent, is likely that we're releasing kind of a pumped state. And I think of my son going to the gym, comes home, he looks bigger, right? He didn't really change that much, but what he did was he feels good because he looks thicker. But and I do wonder whether that is mostly because you're in this kind of constantly contracted state, right? Like a Charlie horse. And so after mavacamten, you release and you change that global phenotype, the architectural change that you talked about, but actually the remodeling maybe not at the cellular level. I was wondering if you agree with that kind of philosophy, or if you've had any preliminary data from your sites or others to support that.
Yes, it's a great question. So I agree with you that a lot of what's been called a mass reduction is probably artificial, because it's the measurement of MRI in hearts that are either contracted or released. And that makes a lot of difference. To me, that explains most of it. Having said that, we have preliminary data in our lab that shows that, interestingly, myosin inhibition has a very quick sort of negative feedback on protein synthesis in the sarcomere, in the cardiomyocytes. And if you think about the amount of protein synthesis that has to occur to keep the sarcomeres going, and it has to occur right at the site, because it's very, very quick turnover of the proteins. It's a massive, massive amount of protein synthesis. And if you shut that down, that probably per se will sort of reduce myocyte hypertrophy, mitochondrial size, a number of things, because the energy consumption is immediately sort of reduced quite dramatically. So that is probably a mix of the two.
Follow-up question to that is that you mentioned many potential mechanisms that mavacamten may actually improve both contractile state, diastolic dysfunction, all those things, but didn't mention microvascular function. I was wondering whether you thought that being in a persistently hypercontractile state may adversely affect microvascular function, and that mavacamten may have a benefit towards improving myocardial blood flow.
Yeah, you're right. That is an aspect that has been scotomized. So in the central part of my career, I focused so much on microvascular dysfunction, and we did all those PET studies looking at. Now we've sort of almost forgotten about it, because we realized that the cellular mechanisms were much more important than the extracellular mechanisms. Having said that, if you look at the microvasculature in these patients, it's completely abnormal, with huge hyperplasia of the intima and the media, and their coronary reserve is completely reduced. So I think it's not easy to make that go away. But at the same time, so we do so this troponin go down. And we wonder, is that because it's the apoptotic energetic side of things that's improving, or is there's definitely probably a great improvement in stress, wall stress. We've seen that from this GLS studies, for example. So I would imagine that there's a bit of both. I would be curious to see whether there's an improvement in coronary reserve. I would be very curious to see that. In fact, that is something that probably one of the first things we should do, probably by MRI at this point rather than PET.
So thank you for a great talk. We've had very favorable experience so far with MAVA in our community. It's been great to be able to have access to this drug. So what has been your experience so far in ventricular arrhythmias and the effect of MAVA on that? Because I'm still wondering, as you know, are the ventricles thin out and you get remodeling, if we're going to actually see improvement in arrhythmia risk?
Honestly, no big signals here. Again, if you look at the big events were so rare during the trials that, in Explorer, only one patient died suddenly in the placebo arm. That's it. So you can't really draw conclusions. Even in the long-term extension, we now have data up to 180 weeks for Explorer. But, it's the rate of events is so rare that it's hard to draw conclusions. In terms of looking at ectopic burden or non-sustainability, the software endpoints, we have not looked at this systematically, but I can't say I've seen an awful amount of. I wouldn't be surprised to see something if you really look for it granularly, but we have not done it just because it's it's not very rewarding. You should put loops on these patients or aggressively monitor for it, and they're so happy with being better symptomatically that you don't feel like putting them under further investigation. But I agree with you, it's a great point. I mean, what I'm expecting to see is some signal from the real world. When you start getting together thousands of patients, and then if you compare with historical trends, I am hoping to see a decline in the point here is that a lot of the sudden deaths occur in patients that have little symptoms and sometimes don't have obstruction at all. So they still don't have access to the drug. Patients who are obstructive are treated more aggressively. They are sort of followed more carefully. If they have risk, they have a device. So we'll see. It's definitely one of the most interesting sides of things.
Along the same lines, are the changes you see in the ECG early or late compared to the changes you see in the muscular?
They're actually early. They're actually early. You can see it happening with MABA in the first 2 to 3 weeks, and aficamten even earlier than that. And I'll be honest with you, if I don't see changes in the ECG, I'm concerned that the drug should be up titrated, particularly in non-obstructive disease, because of course we're still in trials. But if you don't have any other marker of, because if you have a gradient, you can monitor the gradient. In non-obstructive disease, I would expect to see some changes, some improvement in repolarization, to be sure that the drug is there in a consistent. And otherwise, I would be concerned that we are underdosing it. But just my impression.
One question on the chat there, and I think we'll leave it at that.
Disopyramide in RASopathies, absolutely yes. We use it a lot in children, and it's a very safe drug, and we have used it in children. Unfortunately, especially the very small children with severe hypertrophy with severe obstruction, sometimes RASopathies have both right and left outflow obstructions dynamic, and it doesn't work that much. So in the cases you most want it to work, it doesn't work as much as you want. A gradient just remains or recurs.
Well, we're at the top of the hour, so I want to thank you. That was a wonderful talk.
So
See ya.
Are you on site today? Yeah.